Hi, and welcome to episode 88 of the Pet Behavior Chat. So in today's episode, I thought I would chat a little bit about serotonin syndrome. And the reason for that is that is probably the most commonly voiced concern that I hear veterinary professionals and other professionals talk about when they're talking about medications and especially combining meds. So I'm a consultant on VIN, so the Veterinary Information Network, on the behavior folder. And that is something that comes up time and again, is clinicians being concerned about combining perhaps something like fluoxetine together with trazodone because they're really concerned about serotonin syndrome. And I think while that absolutely is a very, very great way of thinking about things, and it can be a valid concern, what it actually looks like in reality is potentially a little bit different. So even though we do talk about serotonin syndrome, it is an obvious risk. I think in relation to how we use therapeutic psychopharmacology and behavior meds, it's something that myself and colleagues around the world see quite rarely. Having said that, though, I think it's worth knowing about, especially if you are starting to use psychopharmacology. And at the end of the episode, I'm going to share with you a couple of papers that were published in an emergency room setting of cats and dogs who ingested serotonergic agents, and actually what is the true prevalence and relevance of serotonin syndrome. So it's something that I think we need to think about. Serotonin syndrome is described as the most severe side effect of serotonergic medications. It absolutely can be fatal, which is why we need to pay such close attention to it. But I think we need to understand what is its true practical relevance and how concerned do we need to be about it. So let's start off with that definition. And it's exactly what I've just said. So it's the most severe side effect of serotonergic agents. It can be fatal. Now, Dr. Karen Overall, in her book, The Manual of Canine and Feline Behavior, she actually mentions that serotonin levels need to be elevated between 10 and 50 times above normal, above baseline, for toxic effects to become apparent. So I think that's something already to start thinking about when we're thinking about, well, how much does serotonin need to be elevated in order to get these signs? And that's what the textbook says. I know it's probably going to be quite difficult to actually measure that and to have an understanding of that, but that's what we're dealing with. Now, we have a couple of published criteria, which I think give us a bit of a reference or a bit of a guideline for when we might start to think about serotonin syndrome, also known as serotonin toxicity, because that's essentially, I guess, what we're dealing with. So the criteria, we've got the Sternbach criteria and also the Hunter serotonin toxicity criteria. And I'll just quickly chat you through these just to help you start or help you understand what you should be thinking about when you're thinking about, could this patient be experiencing serotonin syndrome or not? So the Sternbach criteria state, in order to be considering serotonin syndrome, you have to have had the recent addition or increase in a serotonergic agent, the absence of other possible etiologies, and I'll chat through some differential diagnoses in a little bit, no recent addition or increase of a neuroleptic agent, and at least 3 or more of the following symptoms. And I'm going to chat through the symptoms in a second. So at least 3 or more of the symptoms that we commonly associate with serotonin toxicity. So those are the Sternbach criteria. Now, the Hunter serotonin toxicity criteria state that in order to consider serotonin syndrome or serotonin toxicity, there has to have been the history of serotonergic agent ingestion or overdose. And the overdose part's going to become important when we talk about the papers later. And the presence of any of the following sets of clinical signs. And there are 5 sets of signs, including tremor and hyperreflexia, spontaneous clonus, muscle rigidity, hypothermia, inducible clonus or ocular clonus and either agitation or diaphoresis, which is sweating, inducible clonus and either agitation or diaphoresis. So they're very specific about a combination of specific signs. So those would be the first things that I would kind of think about. So if I'm suspicious of a patient having serotonin toxicity, I might go back to these criteria. I might read through them and think, have any of those or all of those things occurred? Is this what I'm truly thinking about? Or do I need to be thinking about differential diagnoses, which, I always need to be thinking about? But that will sort of set me off in the right direction of thinking about serotonin syndrome. So what are some of the signs that we actually look for? What are the clinical signs that we would see? And when I was studying for boards, I actually found it really helpful to kind of group the signs into sort of 3 big groups. So I had my first group, which are the cognitive or mental/behavioral signs. So that could be disorientation, confusion, agitation, restlessness, coma, anxiety. So those are sort of my more sort of cognitive or mental signs, if you like. The second big group would be neuromuscular signs. So we're thinking about ataxia, hyperreflexia, myoclonus, muscle rigidity, tremor, seizures, nystagmus, shivering. So those would all be these neuromuscular signs. And then the third big group would be my autonomic nervous system signs. So fever, shivering, diaphoresis, which is that sweating piece that I mentioned, potentially diarrhea, nausea, abdominal pain, hyper or hypotension, and tachypnea and tachycardia. So elevated heart rate and elevated respiratory rate. And this is actually also a really important piece when perhaps you are concerned about serotonin syndrome after you've maybe prescribed medications and you're sending the patient home and you want to give the client something to monitor for, or maybe the client is somewhat knowledgeable, maybe they're from the medical profession and they want to be able to monitor their pet for signs of serotonin syndrome. And there the recommendation is to teach them how to take their pet's pulse rate or heart rate, how to count their respiratory rate, potentially how to take a rectal temperature, and how to look for muscle tremors or muscle fasciculations, especially over the extremities and maybe the trunk. So those would be some of the things that if I am concerned, if I'm prescribing a medication, if I'm prescribing perhaps a really quite high dose of fluoxetine, for example, or another SSRI, or if I'm combining that with a higher dose of trazodone, for example, or if I know that the client is giving other maybe natural supplements that have serotonergic effects in addition to maybe my psychopharmacology, those are some of the things that I might ask them to do at home. So get used to maybe taking your dog's pulse rate or heart rate, counting their respiratory rate, know how to take a rectal temperature if you're worried, and how to kind of look for these sort of little muscle fasciculations or tremors. So those are some really practical things that you can ask clients to do at home, especially if you're concerned or if they're concerned, just to kind of add in that additional layer of monitoring there. Okay, so what are our differential diagnoses when it comes to serotonin syndrome? So if maybe you are working in an ER setting or a GP setting and a patient comes in and is showing signs of serotonin toxicity and they are taking serotonergic medications, what are other things that you might be thinking about aside from serotonin syndrome? And we've got a couple here. Now, they're all relatively rare presentations. However, so is serotonin syndrome. So I think it's worth just knowing some of these. So anticholinergic poisoning, malignant hypothermia, neuroleptic malignant syndrome, hepatic encephalopathy, heat stroke. Heat stroke's a big one for me here in the Middle East. And maybe, sort of during the summer or when temperatures rise, that can absolutely be a differential. Myocardial necrosis, infectious or inflammatory etiologies, and obviously other toxicities that might present in a similar way. So just to think about, it doesn't have to be serotonin syndrome. Even if you do have a patient that maybe meets those Sternbach or Hunter criteria and is showing signs of classical toxicity and they're on serotonergic agents, have an open mind, think about differential diagnoses. Obviously, that's really important for us as clinicians to be open-minded and think about other options there. So those would be our differential diagnoses. Now, let's have a think about what actual agents can cause serotonin syndrome. So what are the things that you need to be asking your client? Has your dog or cat taken XYZ recently? Or please list all the medications and supplements that your pet is on. Or you might be seeing a patient that is on psychopharmacology, and you might be admitting them for a procedure, and you might be wanting to prescribe an opioid, for example. Which are the ones that you might need to be concerned about when it comes to serotonin syndrome? So first of all are obviously our serotonergic psychopharmacology agents. So we're talking about our SSRIs, our SARIs, so that's our serotonin antagonist and reuptake inhibitors, so that's trazodone, essentially. Our SNRIs, so that's our serotonin noradrenaline reuptake inhibitors, so venlafaxine would be the most common one there. We would also be thinking about things like buspirone, for example, and any other agents that have serotonergic effects. And obviously our monoamine oxidase inhibitors, that's another really big class. So these are all our serotonergic agents. And, maybe we're thinking about, did our patient maybe just or did you swap them maybe from fluoxetine onto a different medication? So fluoxetine to a monoamine oxidase inhibitor is a classic example here. And did you maybe not leave enough washout time in between? So anywhere where these agents might be combined, and obviously we know we use trazodone a lot as a secondary or adjunct medication, maybe on top of an SSRI. Or a TCA, so our tricyclic antidepressants are also part of this. So any psychopharmaceutical agent that has serotonergic activity. So again, SSRIs, SARIs, SNRIs, TCAs, monoamine oxidase inhibitors, buspirone. So those are your kind of big classes here. Mirtazapine, that's another one. So that is a tetracyclic antidepressant. So, and sometimes we use that for appetite stimulation. So again, think about that. If you maybe have a cat that you want to use mirtazapine on to increase its appetite, is that cat already on fluoxetine, for example? So those are all your sort of typical psychopharmaceutical serotonergic agents. Then we have a whole bunch of other medications, and I just mentioned the opioids, which is another big class because we use opioids so frequently when we are when we're in practice, when we're in a hospital setting. And there are 4 opioids that we need to be concerned about when we're thinking about serotonin syndrome. So the first one is fentanyl, the second one is methadone, the third one is tramadol. That was a very, very common cause, I think, of serotonin toxicity. And there is a paper out there looking at tramadol and serotonin toxicity, which I'll add into the show notes. And then the final one is pethidine. So in the UK, we call it pethidine. In the US, I think it's called meperidine. So that would be the 4th opioid that we would be thinking about. And then we have some other medications that are used for other presentations that might not be to do with behavior. So we've got some cough suppressants. So we're thinking about dextromethorphan there. We've got, for example, some antiemetic agents. So metoclopramide and ondansetron. So those are serotonergic agents. We have a number of supplements or natural agents, should we call them. So the big ones there would be St. John's wort, and then L-theanine, obviously, which is our serotonin precursor. So anything that might contain L-theanine. So for example, our Royal Canin Calm diets contain L-theanine. I know some of my clients have given L-theanine supplement on its own before. Serenicare, which is a new kind of pre and postbiotic by Protexin that also contains L-tryptophan. So those are things also to be asking about. And then 5-hydroxytryptophan, which are griffonia seeds. So again, they're available in, kind of human natural sort of healthcare shops. And sometimes they can be used as well as calming agents or are marketed as calming agents for our pets. So that's something to ask about. And then, of course, our endocannabinoids. So we know that, all CBD products, endocannabinoids, are gaining in popularity around the world, and they can also cause serotonin syndrome. So a number of natural products that I think, always need to be asked about. St. John's wort's a big one. So always ask your client, what else are you giving your pet? What diet are they on? That, even things like that. Are they taking a probiotic? Are you giving them any other natural supplements? Ask them to show you or name the supplement, go online and look at the active ingredients and just ensure that there isn't any kind of precursor. L-tryptophan. I said L-theanine earlier. So I think L-theanine also, so angstine also has serotonergic activity. And of course, L-tryptophan and 5-hydroxytryptophan. So anything that is a precursor to serotonin, and L-theanine, which is our green tea derivative. So L-theanine, which, like I say, is in angstine and a couple of other products, calming supplements. So both of those, so L-theanine and L-tryptophan. I think I got that mixed up a second ago. So just to be clear, L-theanine and L-tryptophan are different. L-tryptophan is the serotonin precursor, and then we've got our griffonia seeds, which is one step further in the enzymatic process. So it goes L-tryptophan, 5-hydroxytryptophan, and then we go turns into serotonin. So that's kind of the how serotonin is produced in the brain from its precursors. But all of those are really important to think about. We've got other potentially natural substances that can affect serotonin pathways. So ginkgo biloba, which also is in some supplements. So yeah, there's a whole bunch of stuff that we need to be asking about. Some antibiotics, also obviously substances of abuse. So MDMA, ecstasy, LSD, those are all things that we need to potentially be thinking about. It might not be perhaps that easy to question clients about that, but those are things that we need to be thinking about. Antiemetics, as I mentioned, ondansetron and metoclopramide. So yeah, a whole bunch of things. Amitraz, which is an old antiparasitic treatment, a wash. So that is a big one. So lots and lots. And if you're kind of concerned or worried, or if you've got a list and you're not entirely sure if they're serotonergic, then just, get the clients to give you a list and just go through each one by one and just see if they have any serotonergic properties. So potentially there is quite a lot there. I would say probably the most common ones that we would think about are our psychotropic medications, maybe our opioids, maybe some of the other medications that we use, such as antibiotics, antiemetics, and then that big class of natural supplements, which are really important to go through and just establish one by one. Okay, so if you now have a patient and you do think that they are suffering from serotonin toxicity, what treatment options do we have? So what are the things that we can do? And I guess the first thing to say would be that we would treat it just like any other toxicity. So we are absolutely thinking about symptomatic treatment. So treating it like any other toxicity, supportive intravenous fluid therapy, addressing hyperthermia, for example, perhaps activated charcoal if the ingestion has been recent, and inducing emesis. So all of those classic things that we would do with any sort of oral toxicity, I guess. And then we've got a couple of other things that we can do as well. So cyproheptadine is one of the agents that is used frequently. So it is a non-specific 5-HT1A and 5-HT2 antagonist. Can be given either orally or rectally, and the dose would be 1.1 mg per kg, and that can be repeated every 4 to 6 hours. And that's probably the most common treatment that I have seen noted. Other medications that are anti-serotonergic would be acepromazine, for example. That's a 5-HT2 antagonist. So that absolutely can be used as well. Then we might think about treating symptoms in terms of muscle tremors and maybe seizure activity. So whatever you need to do there, but benzodiazepines can be really helpful there. We might think about beta blockers to control tachycardia. So again, we're looking at it from a symptomatic point of view, but we have got a couple of agents that we can use that are anti-serotonergic or that are serotonin antagonists. So again, cyproheptadine is a common one there, acepromazine or chlorpromazine, for example, and also ergot alkaloids, although this is a less common thing, is also a serotonin antagonist. So a number of things that we can actually target specifically serotonin activity, and then the rest would be symptomatic treatment. So supportive care, obviously, and making sure that the patient is comfortable and that we're treating whatever symptoms come up. So that would be sort of the treatment for serotonin syndrome or serotonin toxicity. And then I just want to finish off by talking about a couple of papers that I thought are really interesting. So one of the papers I mentioned earlier, which is tramadol and serotonin toxicity. So that's definitely a paper that I'm going to put into the show notes. And then we have another two papers that were published from an ER perspective. And we've got one paper for cats and one paper for dogs. So the title of the cat paper is Selective Serotonin Reuptake, so SSRI Toxicosis in 33 Cats. It's from 2013, so it's a slightly older study. And basically, these were 33 cats that were presented to the ER because they ingested their owner's SSRIs. So they got hold of a pack of their owner's medication and ingested that. And the most typical SSRIs ingested were venlafaxine, fluoxetine, citalopram, and escitalopram. So 3 SSRIs and 1 SNRI. And obviously the owners must have realized this and then taken the cats to the ER. So what did they actually see in the ER? So 24% of those cats became symptomatic and 76% remained asymptomatic completely. So that's the first thing to note. And the numbers are really similar for the dog study. So only about a quarter of the cats actually showed signs. And the signs that they saw were sedation, GI signs, central nervous system stimulation, cardiovascular signs, and hyperthermia. So those sort of classic signs of serotonin toxicity that we spoke about earlier. And but I find this so interesting because even where we had a cat that ingested potentially, quite a few of their owner's medications, which probably would have been like quite a high strength tablets or, higher than we would maybe prescribe for a cat, for example, only a quarter of those cats became symptomatic. And then when we look at the dog paper, so this was on a much larger number of dogs, 313 dogs. So this was a retrospective study on toxicosis from SSRI ingestion. So we had 313 dogs, a study from 2012. So also a slightly older study. But again, we had only 23% of those dogs became symptomatic, 77 remained asymptomatic. And what were the signs that were seen? So neuroscience, depression, ataxia, hyperactivity, again, GI signs, cardiovascular signs, respiratory signs, and inability to thermoregulate. So the sort of classic signs of serotonin toxicity. And again, really similar numbers to the kitty cats, which I thought was so interesting that, a quarter of that population became symptomatic, the others remained asymptomatic. Now, we have to obviously distinguish here. This is, a one-off acute ingestion of probably their owner's medication. That's different to, medications being prescribed to a patient and then maybe ingesting them over a longer period of time, or maybe, they've been taking I don't know, supplements, natural supplements that are serotonergic for a long time, and now we're adding in a psychopharmaceutical. So also this is really important when you're prescribing meds, when you're thinking of starting a patient on psychopharmacology, to ask, those questions. Are you giving any natural supplements? Are they taking any other medications regularly? So those things are really important. Or have they had other medical treatment recently, for example? So those things are really, really important. But yeah, so those are some of the big things to think about in terms of what are the signs, what are the differential diagnoses, how do I treat, what agents do I need to be thinking about, what do I need to be asking about. So I just thought that it would be important to chat through this. Now, from my own personal experience, I have seen now almost 500 clinical behavior cases, the majority of which I have started on a psychotropic agent or 2 or 3. And I, touch wood, in my career have not yet seen serotonin syndrome. And when I speak to my colleagues around the world that have been doing this work for a whole lot longer than I have, it's extremely rare that people have seen it. So I always, I guess when I'm advising about serotonin syndrome, and as I mentioned in the VIN folder, this is something that comes up so frequently. It's obviously, we always have to think about it because it can be very severe and it can be fatal. So we always have to think about it. I think also it's really important for each clinician to act within their comfort zone. So if you're perhaps not that familiar with using psychopharmaceuticals and you are concerned about it, then stay within your comfort zone. Stay at dose ranges that are lower, maybe choose something else. If you don't want to combine trazodone with fluoxetine, then choose a different agent. So I think it's always really important to be aware and to be cautious, to act within your comfort zone, where you feel comfortable, where your client feels comfortable. It's something that you definitely want to mention to your clients. If your client is concerned, if you're concerned, teach them how to look for the signs, early signs at home. However, in my experience, it's not something that we face often clinically, certainly from the psychopharmaceuticals that we prescribe. Now, if we've got psychopharmacology on board and a patient goes into the ER or hospital and is treated with opioids for a longer period of time to manage acute pain, perhaps, yes, those situations maybe need different consideration. But if we're thinking about combining an SSRI with trazodone or those kinds of things, I think we can probably do that relatively safely at the doses that we use. I think monoamine oxidase inhibitors probably within our psychotropic meds would be the only class where I would say be really cautious. Make sure if you're switching from a monoamine oxidase inhibitor to a different medication, or from a different medication to a monoamine oxidase inhibitor, make sure you have that washout time in there. Part of it is because of the irreversible binding nature of the monoamine oxidase inhibitors. So it's going to potentially take longer for those serotonergic effects to wane. So yeah, that would be the group of medications within our psychotropics that I would be most cautious about. And then obviously any meds that are serotonergic that are in sort of the ER general hospital setting. And yeah, then those supplements that sometimes we're a little bit blindsided by, right? Because we think we've prescribed safely, and then all of a sudden we find out that the owner is giving endocannabinoids at home, or St. John's wort, or I don't know, an L-tryptophan supplement or an L-theanine supplement or something else. So that's something to always ask about. So I hope that this has been useful. It's quite a big topic and it's one that comes up so frequently. So I hope I've shed a little bit of light on serotonin syndrome and maybe what you need to know. And like I say, it's just, act within your comfort zone. If you don't feel comfortable with something, just don't do it. But I also wanted to just, I guess, shed some light on how frequently/infrequently we see that as veterinary behaviorists from prescribing the psychopharmaceutical meds that we routinely prescribe. So I hope that's been helpful. I will drop the the links to the papers I mentioned in the show notes. So that's the tramadol paper. So it's toxicity in a cat, actually, tramadol toxicity in a cat. Serotonin syndrome, that's from JFMS from 2014. And then the other two, those ER papers from 2012 and 2013 on the 33 cats and the 313 dogs presented in an ER setting. So I'll put those in the show notes. And then obviously, if you want to learn more about psychopharmacology, and if you want to learn more about serotonin syndrome, then I really would recommend my psychoactive course. There's a whole lesson just about serotonin syndrome in there. And, there's quite a sort of deep dive into all the different medication types and the different types of serotonergic agents and how to safely use them and combine them. So I'm going to also drop the link to the psychoactive course in the show notes. And at the time of recording this podcast, which is summer 2025, I actually have a 50% discount on the psychoactive course for the summer. So that is with the discount code SUMMER50, so SUMMER50. So if you're interested in the psychoactive course, which is truly, truly an amazing course, in my opinion, then now's the time to jump on in with the discount offer. And if you want to learn more about safely using psychopharmaceutical meds, this is absolutely the course for you. So I hope that you've enjoyed this episode, and I look forward to seeing you next week for episode 89. Bye for now.